Great. Thank you so much. And thanks to Dr. Enriquez for your presentation. That was really, really striking. And I think it really helps to illustrate the reality of what providers are managing and dealing with. So some of this, I suppose, research might look a little bit pat and a little bit sanitized from what the reality is in the emergency department, but I'm hoping that it can illustrate the value of continuous quality improvement in the emergency department for, in this instance, improving suicide prevention practices. So I'm going to give an outline of the particular study and then maybe talk about some special considerations for youth suicidality. So I'm really happy to present today on behalf of my co-authors who are listed here. My name is Celine Larkin. I'm an assistant professor in the Department of Emergency Medicine at UMass Chan Medical School. I'm not a practicing physician. I'm a PhD in health services research. So I'm just constantly in awe of the emergency providers within our and beyond our system who are on the front line. So I have no conflicts of interest to declare, and the research that's summarized here was funded by the National Institute of Mental Health. So I'm going to be speaking today about the public health issue of suicide. So I saw this really poignant quote a few years ago, and I think it's really sums up the impact of suicide, that it has a blast radius, and if you're within that blast radius, you are forever affected. 30 to 50% of Americans know somebody who has died by suicide, and more recent evidence has suggested that over 130 people are affected by every fatal suicide. So we're thinking about family members, parents, neighbors, friends, colleagues, and schoolmates. So it's really this, I guess, extended effect of suicide within the community. And those who are bereaved by suicide are in turn at higher risk of mental health issues as well. So the healthcare setting is a particularly good place to detect suicide risk, and the emergency department even more so. So many of those who die by suicide have interacted with healthcare services in the year before death. So in the sample of adults, we saw that over 80% had some sort of interaction with a healthcare provider in the year before death, and actually 50% in the 4 weeks before death. And what's really interesting, there's two really interesting things. One is that the most common types of healthcare visits were actually not behavioral health related necessarily. So if we're relying on behavioral health indicators to capture suicide risk, we might be missing out an important group of people who are at risk. And then the other thing is the high risk or the high utilization of emergency departments by people who are at risk of suicide. And they may be using the emergency department as a resource because they're not currently connected with adequate outpatient psychiatric or psychological services. When we look at emergency department patients in particular, we see that there's a high kind of saturation of suicide risk within that population. So when they're screened sort of thoroughly by research staff in the emergency department, between 2.5% and 8.5% of people endorse active suicidal ideation, and upwards of 15% have some element of suicide risk, passive suicidal ideation, or a lifetime suicide attempt. So it's a really, I suppose, risk saturated location or venue. The issue, of course, is that it's very, very difficult to implement interventions within the emergency department setting. It's really a huge challenge. So many medical patients have latent suicide risk, and just to kind of allay any concerns around suicide screening, there's a lot of evidence now, even randomized controlled trials, to support that asking about suicide does not cause a person to become suicidal. I think there was initially concerns, especially around asking young people about suicide, that it would potentially increase their risk and kind of give them the idea, but that is not the case. So that's been shown with very rigorous evidence. So the, I guess, protocol that we follow within the UMass Memorial Healthcare System, and is becoming more widely adopted as well, is to initially do primary screening for suicide on a universal basis. And the idea of that is to detect if any non-negligible risk exists. And then people who screen positive on that primary screener then complete secondary screener, which helps to stratify risk to drive action and implement safety precautions. So this became especially important in the last few years with the changes in the Joint Commission requirements around suicide safety precautions. So it's important to detect if people have suicidal intent and plan, and really kind of put safety precautions and supports in place for those people. So we administer our suicide screening during triage or initial nursing assessment. We use it with all patients in our healthcare system who are 12 years and older, regardless of their presenting complaint. And that primary screening helps to determine the presence or absence of suicidality. And there's 3 questions within the screener. So the first is kind of a warm-up intro framing question. In the past 2 weeks, have you felt down, depressed, or hopeless? In the past 2 weeks, have you had thoughts of killing yourself? And then in your lifetime, have you ever attempted to kill yourself? And when did that happen? So if a person endorses thoughts of killing themselves in the last 2 weeks or an attempt in the past 6 months, they are defined as a positive screen and they enter our care pathway. They're then asked 6 additional secondary screening questions, which allows us to stratify very early in the visit. So we're kind of aware of the person's level of risk very early. So I guess in response to a positive screen, what interventions are potentially feasible within an emergency department setting? So one intervention, it's referred to as a brief intervention, although I think 20 to 25 minutes in an emergency department setting can seem like a really long time. So the safety planning intervention has a significant amount of research support, again, in randomized control trials and meta-analyses. And so the safety planning intervention is not the same as contracting for safety. So there's some kind of outdated kind of notions around contracting for safety. I suppose having a patient promise that they won't hurt themselves, that is not an evidence-based strategy. So this is different. This is a prioritized list of coping strategies and resources for use during a suicidal crisis. And it uses a collaborative approach with the patient. It helps to provide a sense of control during crises, and it's really in the person's own words. So it's a very personalized and personal plan. It can involve linking with family as well to help share and implement the plan with the patient. Usually takes at least 20 minutes to administer. And this is the what's called the Stanley Brown safety plan. So this is kind of what it looks like in practice. So these are the 6 steps. So that when to use the safety plan, how to cope internally, ways to distract oneself, getting help from loved ones, getting help from professionals, and reducing access to means. I'll come back to that access to lethal means in a moment, because it's a really, really important piece of youth suicide prevention. So in the ED Safe study, which preceded the ED Safe 2, it was shown in 8 emergency department sites across the country that universal screening was indeed feasible, that it worked in the emergency departments, that it didn't break the, excuse me, it didn't break the emergency departments or cause a inordinate increase in the number of evaluations. And it successfully increased the detection of risk in emergency department patients. So it detected an additional cohort of patients who were maybe presenting with non-behavioral health concerns or not with sort of frank suicidal crisis, who actually were experiencing suicidality and were referred for intervention. So the ED Safe 2, then following on from that research, used a stepped wedge cluster randomized control trial. So this is where our sites went live in cohorts of 2, and those cohorts went live 2 months apart. And the value of that design is that allows you to parse out whether there was any kind of secular events that might have impacted implementation during the period, rather than having all sites go live at the same time. We used an interrupted time series design, sort of pre and post go live. And the goal for each site really was to improve screening and see whether screening could be sustained. So the screening that had been implemented in the first ED Safe study, whether that was able to be sustained, and to implement this safety planning intervention in their emergency departments. And then we gathered data from a random sample of 25 patients per month per site who were aged 18 and older. So that is a caveat here that this is an adult study. We screened using the patient safety screener, and the sample were discharged from the ED. So the sample was restricted to those who were discharged from the ED, and the primary outcome was a composite behavioral outcome. So it was fatal suicide or suicide-related acute care visits in the 6 months afterwards. So the way that we, I suppose, went about improving suicide-related care within these emergency departments was primarily through continuous quality improvement. So I think this is really common across a lot of hospitals now. There are CQI kind of infrastructures in place. So I know at UMass Memorial, all staff are required to attend white belt in lean CQI training when they first start working within the healthcare system. And it's really a way of promoting frontline engagement and bottom-up problem solving, being able to pilot changes to practice and maintaining change as well. So it's really very much in the hands of the clinical teams. So within this EDSAFE-2 study, each of the sites received training in lean CQI. They built a CQI team to evaluate the current suicide-related workflow and to identify areas of improvement. Then they implemented the efforts to improve, and then they were receiving monthly calls with centralized coaching by industrial engineers who are experienced in lean CQI. So this is an example template of an A3. So this was a tool that we used with the sites, where they kind of identified what the problem was, what the current conditions were, what the goals were for their improvements. So they might have an A3 that focused on suicide screening, or an A3 that's focused on safety planning. Some of the emergency departments had additional A3s around creating safe rooms, you know, ligature-proof environments, and some other kind of, I guess, homegrown concerns around suicide-related care that they wanted to work as a team together on. So they had their local team within their emergency department with representation from a variety of types of providers and clinicians in the emergency department. And then they also had this kind of coaching from a centralized team. So in addition to the kind of CQI, or I guess hand in hand really with the CQI efforts, were changes that were made to the electronic health record as well. So it's very helpful to think about the electronic health record as a resource within this work. And I know that Epic, for example, is doing a lot of making a lot of changes to their foundation system to give support for things like screening and safety planning within the healthcare system, because EHR can serve as a reminder. It can provide structure for clinicians, documentation around billing. It allows people who are interested in quality improvement or researchers to complete or to monitor the completion of these different clinician behaviors, and to monitor the fidelity to the interventions as well. So it's a really helpful resource in our area. It's not everything because it needs to go hand in hand with, you know, helping people improve their skills, you know, addressing some of the attitudinal barriers. So there's a lot, you know, kind of providing resources to make sure that people are actually able to do this work, but the EHR can be a helpful way to organize some of that work. So within the EDSAFE-2 study, what I think was really striking was that during the baseline, so this is after the grant support from the first EDSAFE had been, you know, had gone away and the sites were sustaining universal suicide screening on their own, they still were doing suicide screening for the vast majority of their patients. So 89% of patients were still being screened, which was really great. And then the CQI efforts helped to sustain and even improve those screening rates further. There will probably be always a small percentage of patients who are just not able to participate in screening for different reasons. They may be intubated, they may be completely overwhelmed. Like there are reasons why a small portion of patients will not be screened. We found that the detection rate was pretty high, so 5%. And that stayed solid. We found that it did kind of decrease during maintenance. I think as those CQI activities started to slow down during the maintenance phase, and we had quarterly calls with the sites, and we found that there was a decrease in detection during that maintenance phase. And then we looked at the outcomes for suicidal behavior, and we found that the likelihood of having a suicide behavior outcome among patients who presented to these emergency departments and screened positive for suicidality, their likelihood of engaging in suicidal behavior in the 6 months after their index visit was lower during the maintenance phase than during the baseline phase. So there was a significant reduction in suicidal behavior associated with this program. So as I was preparing for this presentation, I was thinking about how we might do things differently for youth. So certainly in terms of suicide screening, there is a suicide screener that was really explicitly designed for young people. So it's ASQ, and it comes from Lisa Horowitz and her team. So while we have used the patient safety screener in patients older than 12, the ASQ was really designed for with children in mind. So it's been used in samples as young as 10 years of age. And that's a helpful screening tool even for preteens. And this is a really interesting paper that showed that there was still significant prevalence of suicide risk, even in patients that are younger than, what we would typically expect. Another consideration, I think, especially for youth, is around kind of the safety precautions and really balancing physical and psychological safety within the emergency department. It's a huge kind of concern. So one of the things that we ran into with our pediatric efforts within our own healthcare system was, can a parent or caregiver be an observer, one-to-one observer for a patient? Like, how do pediatric patients fit in with these like Joint Commission guidelines around the requirement for one-to-one observation of high-risk patients? So trying to navigate, I think, what the accreditation kind of requirements are around safety and observation while still being sensitive to the patient's psychological safety. So one of the most important things for people who are presenting with suicide risk is to have a sense of connection. So that psychological safety can really be helped by having compassion and connection with their carers, feeling acknowledged as a person, not feeling depersonalized or dehumanized by some of the precautions that we're taking, making sure that they feel protected, from their, I guess, suicidal intent, but also receiving support from observers, and observers being allowed to maybe interact with patients in a supportive way, and making sure that we're able to train our observers to have that kind of capacity. And then another aspect for psychological safety for people in crisis is that kind of aspect of control and feeling like they are able to cope with their difficulties and symptoms, and I suppose feeling empowered by the providers that they're seeing. So there's a lot to that kind of balance, and obviously we don't want people to be in physical danger while they're in the emergency department, but it's also important to think of their psychological safety as well. As mentioned, very I suppose poignantly really by Dr. Enriquez, is the issue of the extended pediatric boarding. So certainly within Massachusetts, this is a huge issue. Finding inpatient behavioral health beds for pediatric patients is a huge challenge, and it seems to be getting worse all the time. So thinking about maybe, are there interventions or initiatives that can happen while the person is in the emergency department to kind of initiate some of that evidence-based care, with the caution that some things that might seem like logical solutions may not actually be helpful for youth. So one of our providers recently had the idea to run safety planning intervention support groups, and to do that with adolescents in the emergency department. But one thing to bear in mind is that social sort of contagion around suicide and suicidal behavior is an issue for young people. So just being really, really thoughtful about the sort of practical solutions that we think of for implementing interventions in the emergency department, and definitely involving caregivers and safety planning. So the safety plan intervention really involves a lot of kind of family involvement and engagement and social supports. So maybe even thinking about safety planning with the caregivers in the room as well.
So Lane, so sorry to interrupt. I want to note that we're about at time.
Okay.
Thank you so much.
Thank you. Do you mind if I just take 20 seconds to wrap up? Would that be
Feel
okay?
free. Go ahead. Not a problem. You
Thank
can
you so
even
much.
have 35 if you want.
Oh my gosh, that's a treat. Okay, thank you. So I just wanted to emphasize in particular lethal means restriction and counselling around youth. So we know that the most common means of death by suicide among youth is firearms, and that those who are living in homes with guns are most likely to use those in their suicide attempt, which is then obviously very likely to be fatal. So just to, I guess, pitch for thinking about integrating lethal means counselling as part of your suicide prevention efforts within the emergency department, particularly with youth, and knowing that people do not substitute. So if you remove access to a firearm, they don't necessarily move to a different way of harming themselves, and you may have saved their lives. So just to reflect that universal suicide screening seems to be sustainable, but there's no guarantees around screening fidelity, which I didn't have time to go into, but it's something worth bearing in mind for CQI purposes. The ED setting is definitely unique and challenging, and that brief interventions are not so brief when we're talking about the emergency department, but the CQI can maybe help to address some of these issues with bottom-up problem solving, and just bearing in mind that even in the context of all of the demands that are being put on emergency departments today, the compassion is really the most single most important ingredient in suicide prevention. So even if there's not necessarily the time or training to do really in-depth evidence-based interventions, I think having that compassionate approach with our youth in crisis is really, really impactful. So thank you so much for having me. I'm sorry for going over my 35 seconds.